I've been working a lot, and so my neck feels extremely heavy. I'm bending over a lot. There's a lot of tension in my posterior neck, going all the way up my head. And I don't have great range of motion. And I'm feeling like I'm clenching my jaw quite a bit.
Okay.
And so this whole area, all up and down my traps and my neck, are going into my jaw. And I feel like I just can't move my neck the way that I should be able
Okay.
to.
Is it mostly on the left? Is it the right? Is it both sides?
I think right now I'm feeling more tension and pulling on the left side, but
Okay.
both sides are pretty affected.
And as I recall, you don't do well with cervical manipulation.
Right.
You like gentle, more in the myofascial work,
Mm-hmm.
and the gentle, more induction of movement rather than the forceful movement.
Right.
So that's what we're going to do.
Yeah.
I like to start with a gentle touch. Lately, I've been really kind of focused a lot on the gentleness, like how gentle can I be? How light can my touch be and still feel what I want to feel? And it's surprising because sometimes the answer is the less pressure you use, somehow weirdly, the more you can feel. And I think that's partly because using a lot of pressure can tend to evoke a bit of a guarding response in the patient. And so then you're kind of, you're instigating more tension in their body, which makes you feel like you need to press harder to feel through it, which makes them more tense. And so then you're in a little contest with the patient, which is not really what we're going for, right? And the other thing is remembering that just from a neurological standpoint, I can't actually feel inside the patient. All I can feel is what is happening in my own tissue. And so the texture, firmness, mobility, tone, temperature, bogginess, those are all things that I sense as, when you boil it down, you sense those things as deformations of your own skin and the nerve endings in your skin and your joints. And so how do we minimize the amount of noise in that signal? And I think when you use a lot of pressure and your muscles are really activated, especially the muscles in your hands, that's creating a lot of sensory noise for you, which is going to get in the way of you sensing what's happening in the patient's body. Now that said, I do think that our ability to sense through our skin and our skin receptors is incredible and underutilized in medicine today. Many doctors never even touch their patients, which I think is such a missed opportunity for gathering information as well as creating connection with your patients. And so, obviously, this practice is totally based on the touch. So everyone who comes in here gets touched. So what I'm sensing in Ashley is, I know you were talking about your left side feeling really tense and tight, and I'm keying in on the deeper tissues on the left side, the scalene and the levator scapular region being tight. Also keying in on this right upper sternocleidomastoid, having some trigger point activity in this upper third. You see that a lot on people. And this is very impactful because that SCM attaches to the mastoid process, which is on the temporal bone, but that temporal bone is very closely, firmly attached to the occipital bone. And so when that SCM on the right is tight, it's going to pull that occiput inferior on the right, vice versa on the left. And then when your occiput is stuck on one side or both, it will have a domino effect on the posture through the whole body. So it could be that part of the reason Ashley's neck feels so heavy is that this occiput is not quite sitting right on her atlas. And as you often see, when the occiput is out on one side, you'll see something in the neighborhood of C234 on the other side as it's trying to counterbalance. So it's much easier to adjust C234 than it is occiput. So a lot of times chiropractors who are going for the crack will address the easier one and leave the problem. So I don't want to do that. But in terms of like upper trap tone, it feels okay. It's not super tense and tight. I have to remember that Ashley is a bit hypermobile. And so what's, quote, normal tone for her is gonna be a little bit loosier-goosier than it is for the typical population. So we have to kind of account for that. Any questions so far, Ashley?
No.
Okay, good.
I feel like you're directly talking to me as a body worker because I am a firmer deep tissue massage therapist.
Uh-huh.
And so this is all a great reminder to me.
Good reminder.
Yeah.
May I open this, please?
Yeah.
Good reminder to lighten up. Okay, so I got a little oil on my hands, and we're just going to start warming her up a little bit. Lately, I've been thinking a lot as I work about the nervous system and how your myofascial tone is so greatly influenced by the neurological input that it receives. And so, like, it's one thing if we have a trigger point, right, like we have right here, which is a little irritable area in the muscle. And it's another thing if we have like a postural issue or this whole muscle tight thing, because a lot of times those are actually decisions that are made on the neurological level. And can you affect the tone of a muscle or the fascia by creating better neurological regulation rather than simply like physically stretching or putting pressure on the muscle? That's what I've been thinking about a lot as I work lately. So that being said, I am working directly on this SCM trigger point on the right because in my experience, these are so important and so impactful. And not doing a really big, deep squeeze. I'm imagining it's kind of sensitive.
Mm-hmm.
Yep. So I don't want to, again, I don't want to unnecessarily like challenge your nervous system, but I do want to get in there and manipulate this little piece of myofascia. Yeah, I'm sorry. You okay?
Mm-hmm.
Okay, good. Take a couple deep breaths. And here's, I think, is the center of it. And again, it feels like we did with your QL a few weeks ago, the contracture is at the junction of the deep fascia and the superficial fascia outside the muscle. There it goes. So what I just felt was a little couple twitches under my hand and then a little bit of a release. Good. And we want to remember with trigger points that it's a loss of microcirculation that creates the problem in the first place. And so our goal with treating a trigger point is to restore circulation into there. And then we know that the body will release the trigger point on its own once the circulation has been restored. So you don't always feel an immediate change in the texture of a trigger point when you're working on it, even if it releases really nicely, because it takes time for the microcirculation to come in and work its magic. Good. So here I am giving a little gentle stretch to this right upper trap and getting a little bit of a depression in the scapula. And yet we're stretching fascia, we're stretching muscle, but also kind of thinking about that neurological piece, just sort of like reminding the cerebellum and the brainstem, where all the postural centers are, that like, hey, here's your shoulder. Here's what your right shoulder is doing, and here's what it can do. It does have this range of motion, and would you rather have that shoulder depressed a little bit? Okay, coming up here to the other end of the upper trap, where it inserts onto that all-important occiput right here. So many awesome points right along that occipital ridge. Points on the bladder channel and the gallbladder channel, as well as, of course, So many muscular insertions or attachments. The splenius, semispinalis, suboccipital muscles, upper trapezius, some SCM fibers, lots and lots of non-muscular connective tissue as well.
I have a question.
Yes, of course.
So if this is on the bladder channel,
Yeah.
and I have an overactive bladder, could
Yeah.
it potentially make it less stimulated so that
Mm-hmm.
I'm not?
Yeah.
Oh, wow.
So it works both ways. Working the points can help the organ, and also irritation in the organ can create stagnation along the channel, and that stagnation along the channel will cause blood to accumulate, and that's when you get a little bit of inflammation, a little bit of swelling, and that physical stagnation and congestion that causes muscle pain. So yeah, works
That's
both
awesome.
ways, isn't it?
Mm-hmm.
Very, very cool. Okay, let's come over to the left side here. On the left side, I had keyed in initially to the line of tension being a little bit more here. Levator scapula, scalenes. We want to remember and respect the presence of the neurovascular bundle here. That's her brachial plexus and subclavian artery and vein. We don't ever want to put a lot of pressure on those. So it's really nice to be able to locate it first without pressure, just a gentle touch, and then come off of it. So we know we're not on there, but there's still lots and lots of nerves and lymph nodes, lymphatic vessels, veins, yeah. So the stickiness is right here. That's her first rib. I know it's her first rib because it's way too far lateral to be the spine. It's too far anterior to be the scapula, right? Her scapula is back here, and it's presenting sort of a flat superior surface. That's what the first rib feels like. And it's stuck. It's stuck where it hits C7 right here. Is that sensitive?
Mm-hmm.
Okay. So some patients would do really well with an adjustment to mobilize that rib. And that's not what we're going to do with Ashley because, well, she doesn't want that. And we know that that doesn't work real well for her. So how do we impart mobility in the first rib without using a lot of force? Well, what we want to do is induce. We want to induce the movement that we're looking for. So often what happens with the first rib, and that's what it's feeling like on Ashley today, is that the resistance is to depression. As I'm putting pressure inferiorly on it, it's sticky, it's stuck, it's a lot of resistance. And so can I gently induce a little depression of that first rib? It might look like I'm pressing with my left index finger, but really most of the movement is coming from my right hand on her right side as I'm translating that lower cervical spine, C7, T1, and creating a little bit of motivation, I guess, for that first rib to depress. It just let go a little bit, and it just let go a little more. And as I'm able to kind of switching to my thumb so that I can put a little forward pressure, and now you probably can't see, so I'll take my hand out and show you. I've got the pad of my thumb on the front of the upper trap and the pad of my my index finger behind it, and I'm going to give it a little pinch and lift, which is kind of a classic myofascial technique. Grab it and gently induce some posterior movement and superior movement. So I'm stretching fascia, I'm stretching muscle, I'm opening blood vessels, I'm sending a lot of information into her cerebellum and postural centers. It's definitely a lot of that sensation is coming to her consciousness and may be perceived as pain. And again, I don't want her to induce a lot of a guarding response in her, so I don't really want to cause a lot of pain. But if we have to, in order to get the tissue to comply, then that's what we're going to do. A little bit more mobility of her first rib here, and let's take that out and do like we did on the right side and just help her scapula with a little depression and bring that up to the occiput and work gently along the occipital ridge. Sometimes, that's a beautiful breath you just took there, Ashley. Sometimes you work a spot on a patient, right, and they're like, you could do that all day, right?
Mm-hmm.
I feel like the percent of times that people have said that when I'm working their occiput is probably higher than anywhere else. It just was like, oh my God, like scratching the scruff of a cat's neck, you know, where they're just like, you can't stop. If you stop, I'm going to bite you.
Everyone's drooling.
Exactly. Exactly. I love when cats are mad when you stop, but then they swat your hand away because they don't want you to do it anymore. They're such lovely, inscrutable creatures. Okay, so I'm able now actually to create a little right to left movement of her occiput, really gently by tractioning. I've sort of grabbed onto the fascia on the occipital ridge, and I'm using the middle finger of my right hand to create a leftward movement. And it's really, really gentle, but I can feel the right side letting go, which is what we want. Good. And so now we're going to gently continue these fascial lines. I'm going to work both sides, because remembering the SCM fascia comes up here and actually continues as the superficial fascia of the cranium on the temporalis muscle, which is such an important jaw control muscle, and on the parietals, the frontalis, all these muscles that control, especially the upper half of the face and the scalp. We hold a lot of tension in our scalp. It's part of our stress response. It's almost like our cat hair standing on end, you know. It's part of our vigilance response, holding our eyes wide open and kind of keeping us on edge. And we don't really think about it. We don't feel it the same way that we feel like a tight shoulder or a tight calf. Okay, we're going to transition now into doing some jaw work. I'm going to clean my hands, get the oil off my hands, and put on a glove, and we'll demonstrate some jaw work. Okay, so you get a break.